finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Welcome back, everybody. You're here for another episode of BS Free MD with Doctors Tim and May Hindmarsh. You're watching us on the video, which not a lot of you are, but you'll see we're representing our countries or states. Tim's got his Epic Oregon shirt from 2015 where he ran Epic Race. Do you remember that?
I do. It was really fun, and at the end, somehow we got about 20 beer tickets for pints of
Always comes back to beer.
really strong beer. And contrary to popular belief, I was not going to drink 20 beers, especially after running 18 miles.
No,
so I started giving them away to random, kind of somewhat homeless people in this park, and they were very excited about that.
That's an awesome story. Well, I've got my Roots sweatshirt on. So, hey, Roots, if you want to sponsor us, it's a great Canadian brand. Check them out. You can buy their apparel online in the US, by the way. Super comfy clothes and leather goods. But anyway, enough of that. Today's guest, let's get right to it. We had an amazing time with this interview with Dr. David Rosensweet. And you guys are going to be all over this episode because hormones are a popular topic. And so that's where we're going again today, diving into his thoughts and expertise on hormone replacement therapy for women and men. What's great about this episode is that actually he's one of the original sort of founders of hormone replacement therapy using bioidentical hormones. He's a very early graduate of medicine, a few years ahead of us, as you'll find out. But he actually helped establish what he calls the Menopause method and the Institute of Bioidentical Medicine, where he's been training medical professionals to master bioidentical hormone replacement therapy using his expertise and advanced and modern tools. And he's basically become an expert, an educator in the field in very popular training programs that physicians and providers use, such as the Anti-Aging Medicine College, which is known as A4M, and American College for Advancement in Medicine, ACAM. So if you've heard of those, he is one of the lead educators there. So he's got some great tips. We asked some great questions, and he's got some places for you to go to seek help if you are on that path of wanting to get more information or treatment with hormone replacement therapy. Stay tuned. You're going to love it. All right. And as promised, we are back with our guest this week, Dr. David Rosensweet, who is the founder of the Menopause method and all about hormones. Your questions are going to be answered yet again. I know this is going to be so popular. So thanks for being with us today, Dr. Rosensweet. We're so happy you're here to share your expertise. And I know that the audience will be loving this.
Fun for me, Tim and May. Yes, absolutely.
So why don't you give us a little bit of background on where you did your, training and how you got interested in hormones specifically?
Well, I graduated the University of Michigan Medical School in 1968. You can do the math. And I loved medical school. It was like a church or synagogue for me. And yet at the end of when I was a senior, I started wondering, well, aren't there any other tools? And I learned from local GPs that, B12 injections could make a difference. And a lot of patients were on thyroid. And I really got interested in nutrition and detoxification and exercise and dysfunctional response to stress early on in my career. And then it really developed into me being a holistic or functional medicine doc before there were the names for that. And then in early 1990s, a patient of mine, Deborah, was in her mid-40s, stormed into my office one morning without an appointment, banged her fist on the desk, and I knew her really well. This was a bit shocking to me. And she said, "You got to help me. I'm going crazy, and don't pretend like you think you know me." And
Love it.
and I knew Deborah. What I knew about Deborah is she was brilliant. She had retired in her mid 40s. Think about that. Retired in her mid 40s. And I gave her some progesterone because serendipitously I had spoken with Dr. John Lee. And, 3 weeks later, I got a letter from Deborah saying, I can't believe this stuff. This has made such a difference for me. I'm myself again, totally. And never in my medical days had I ever seen something work so effectively, so easily. You know the drill. By the time patients are ill, it's often a slow moving train to assist them to return to health if you can.
Right.
But I wasn't in control of my practice any more than I believe any of us are. It sort of has a mind of its own, or it's divinely guided, which I really think is the case. And before I knew it, I was seeing a lot of women in menopause because word spread. And it was really a wonderful thing for me because I love biochemistry. I love hormone pathways. I thought they were fascinating. And so in the beginning, I had to figure it out with women because there was so little known. And I had the help of a father, of functional medicine. He had taught me how to titrate thyroid hormone. Start low and gradually increase because there's a variability person to person. And I did that with the 4 ovarian hormones. And I partnered with women. I wrote a book to teach women what I thought would be valuable for them to know. And my God, we built it up from the ground up, really. And I started teaching it. I founded a summit in 2007 to bring together the leaders to see if we could exchange some information so that we could share things. And then, of course, the women wanted their men to be treated as well. So I had the great privilege of lecturing and teaching with 2 world-class experts on treating men. And there we go, a bunch of stuff. About 18 years ago, I had been treating women for about 10 years, and a pharmacist missent one of my patients' estrogen formulations, a topical estrogen called Bias, to my office rather than directly to the patient. I had never seen a hormone. It came in a white cosmetic jar. I broke the seal, opened it up, and out came this strong odor. And I went, what's this about? And because I was interested in toxicity. And long story short, we didn't like what we learned. And my son and I developed and patented an organic oils base to dispense topical hormones with. And so we've got a big project going on. I'm probably talking too much right here at the onset, but
no, this is great. This is great. So
Yeah.
now you like fast forward to currently, are you developing your own hormone products then that are available to your patients, or is it available to anyone that's prescribing?
It's available to anyone who's prescribing. If you have a license to prescribe, it's available to everyone. We supply everything that a compounding pharmacist needs except the hormones themselves, which they have. And we have 34 pharmacies in the United States that are dispensing this. And yeah.
And I think I know that you also have a direct website and access for patients who are looking for help with their hormones to go. And how long has the Menopause method been up? And
it's been up for, in some iteration or another, probably 15 years.
So
the best place these days would be brite.live, BRITE.live, or IOBIM.org. This is because the majority of what I do is I train and mentor physicians and nurse practitioners in advising compounding pharmacists how to treat women and men in menopause and andropause.
Okay.
So if a physician or a practicing healthcare providers wanting help with that, what site is that through? Is that through the Menopause method?
That's through IOBIM.
Oh, okay. Got it. We'll put the links in for that.
Yeah, for sure.
That's right. I looked on there.
So like a question just comes to mind because, we've we've come through this last 3 years where there's been, all of this debate as far as, who are the experts and randomized controlled trials. And, we just had an episode last week with Dr. Harvey Risch about how randomized controlled trials can be entirely manipulated. And, there's so many little details that go into a trial that it's very easy, especially for a gigantic pharma company, to kind of make something say whatever they want it to say. And I mean, he's very erudite in explaining this. So what do you say to the detractors, or to, I would kind of envision it like back in the day when I used to go to the doctor's lounge when I was doing hospital medicine, and they're like, well, there's the nurse's health study, and you can't just give women a bunch of estrogen. Their breasts are going to explode with cancer. And, these kind of things, which intuitively seems nonsensical, since we've had these hormones in our bodies since puberty. Why should it just magically we get older and then we don't need them anymore? But at the same time, there's this sort of pushback from, standard allopathic practice of, well, it's not been studied and I would never give that to my wife, and, these kind of things. So what's your response to that?
Whew. You got about 5 solid, core, important, critical questions within that one question. Let me address it from several different ways. There's been great concern about hormones since the early 2000s. And it's because in 2002, a false reporting of a study came out called the Women's Health Initiative. It was huge. It was one of the most expensive of all times. It was poorly designed, and it was falsely reported. And what it said was that women who are taking hormones are at increased risk for breast cancer. That's not what was in the study, but that's what got reported out.
Correct.
What was in the study is that women taking Premarin, and this is horse urine-derived estrogens, had less of a risk. Because you two will really understand this, the relative risk was 0.79. That means a woman on Premarin had less of a risk of getting breast cancer than a woman who did not receive Premarin. The questionable in the study was Prempro. That's a combination of Premarin with a progestin. And that had a increased relative risk of 1.26, which was reported in the study as being statistically insignificant. But that statistical insignificance was not reported out. And it just it terrified women and providers all over the world.
No, I remember it vividly because in my practice, which I was heavily female-based gynae, and I was prescribing hormones, and then all of a sudden that came out, and we were in the prime of our family practice careers. Yeah, everything just kind of flipped upside down, and so the mainstream, was like, okay, well, this has got to change, stop, and then it's like, where do we go from here? So there was a lot. I felt tons of pushback, and then just a big confusion on how to advise patients. And I was always looked at, well, everybody's individual and unique. Let's look at your risks. That one size doesn't fit all in medicine. But yeah, I'm interested in your journey, because like you graduated much earlier than us, and here you are kind of a pioneer. I'm a pioneer in this. And that's what, Tim's asking, did you get a lot of pushback in the 80s and 90s as you were doing this? And then 2002 happened. So how did you get through that?
Well, I've made it a forever professional policy to not do divisiveness. And so over the course of years, I honor our profession, and I respect differing opinions, and I have gotten in very little challenge because of it. But what happened prior to 2002 is, well, Premarin was the most popular and profitable drug that was ever at the time. 18 million American women, 40% of whom were in menopause, were on it. And when that study came out, the impact was so severe that it got down to the very low millions. And it did another thing. It stunted the medical practice. So while our colleagues were differentiating out into highly specific specialties, which is a great thing. You want to go to a urologist, you want to go to someone or a gynecologist, you want to go to someone who's really had the training in these beautiful programs of residency, etc. But not in hormonal medicine. While these other were differentiating out in specialties, there was no specialty. I'm one of the few specialists in menopause and andropause I've ever met, and I'm really plugged in. And just to go back to the risk, when I read the original Women's Health Initiative, I went, wait a minute, there's no statistical significance to this. And cancer is far more complex than this. And anyway, I was not, it did not slow me down. And just like you were saying, May, it was a matter of individual risk. And then I followed the literature. And by 2006, it was very clear from the literature that there was no increased risk, but no one heard about that. Mm-hmm. And in 2016, the original Women's Health Initiative Study Committee published in the original journal, the Journal of American Medical Association, that after 18 years of follow-up, there was no increased risk in breast cancer, heart attack, and stroke. That's published.
Yeah.
Same committee.
But you don't hear that, and what the damage had been done, and across the board, and so
right. And as you described about Deborah, there was probably an increase in spousal homicide.
Yeah, among many other horrible things that took place.
Right.
And the great news is, for anyone who's really interested in risk, is there's a oncologist who specialized in breast cancer. His name is Avram Blooming. And his partner, Carol Tavris, have written a book called Estrogen Matters. And anyone who really wants to learn about risk should go to that, because there's 450 references. This is not just me saying, oh, it's risk-free. It's the whole story. And I'm sure our staff has given you an opportunity for people to download a free PDF copy of my book. In chapter 3 on risks, I describe the overview of what's true. It is creeping back into medicine, but very, very slowly, that women who are on hormones and men who are on hormones, that's also true, do better in every way, including less risk for breast cancer, heart attack, and stroke. It's creeping back in. Last published data was about 6,000 women were back on hormones. And over half of them were on compounded bioidentical hormones, because the compounded bioidentical world, it never stopped flowing.
Right.
Many people were just like me. We went, wait a minute, this isn't even science. And so
let's talk about that. What I still see it now, although this has become, I would say over the last 5 years, we see just a giant explosion in ability for people to be aware about hormone replacement, to find places that prescribe it. Maybe, a little more difficult, and depending what state you're in and where you live. But as a physician myself, and as someone who was starting to go through menopausal symptoms in my 40s, I would seek out colleagues, my own PCP, gynecology, and I was devastatedly pissed off at how they blew it off, and they'd say, well, your only option is, Prempro or Premarin, but you're not in menopause, and your levels are fine, and forget the symptoms, and then, the risks, and nobody, and then I'd say, well, what about bioidentical, creams, topicals? Well, we don't do that. I don't know anything about it. The only people I could find doing that would be our naturopath that we used. And then even 3 years ago, the gynecologist that I still see, she's like, well, I don't know how to do that. I'm not really that trained. I can give you maybe some topical testosterone, but my PA, she's taken some classes in it. And the PA, it's basically, well, all we'll use is the commercial, nothing bioidentical that's compounded, just the not Estratest. What am I thinking of? I'm drawing a blank.
I have no idea what you're thinking.
Anyway, it's just a mainstream giant pharmaceutical brand. Why have
No,
I
and it's
drawn a blank?
I have been doing
Nothing compounded, but it's basically, well, you just have to get the mainstream stuff. Nobody here knows how to do it unless you go off into the alternative medicine world or a naturopath's office. Why is there a big block in Western medicine prescribing physicians, especially gynecology offices, to do this? You think that you're the expert, you're the gynecologist that studies women's hormones the most for the most amount of years. Any thoughts on that?
Yeah. Well, I'm not a gynecologist. I did an internship, a rotating internship, and that was the end of my formal training in that regard. But I definitely zeroed in, and
Right.
yes,
You've educated yourself and have become
definitely.
the expert, but I'm thinking this makes no sense to me. Who a woman's
Well, I have opinions on why that's the case, because I think that we've trained the last generation of physicians
Yeah.
to just do what they're told.
Yeah.
I mean, anything. And again, I don't want to bunny trail too badly, but the day they recommended the COVID vaccine for children 6 years and under is when my head exploded, and I said, "This is so beyond the pale of common sense that if you're going to a doctor that recommends this, they are an unthinking beast.
That's right.
You should take medical advice from your Labrador Retriever, because at least they're cute."
Well,
But-
here's what I've noticed is that in almost every field, and especially medicine, there's a couple of factors that prevail. One is that there's a 30-year lag time between when the good stuff starts getting known and when it starts getting popular. Like in 1970s, I was hired by the state of New Mexico to write a paper on nutrition. And this medical doctor at Harvard, his name was Kilmer McCulley, had come out with something about homocysteine and its relationship to risk. And I started to write about it for the state of New Mexico, and it got totally lost in the wash. And then in the 2000s, 30 years later, I'm driving and I hear on NPR, there's been a brand new discovery in cardiovascular medicine by a Dr. Kilmer McCulley, who, by the way, was bounced out of Harvard for writing that.
Wow.
In the relationship of B6 and B12 to the assisting of the homocysteine issue. 30-year lag time. It may not be 30 years, but it's pretty close. And what we can count on our traditional colleagues to be good at very often, not perfect, I mean, we're human beings, but there's a lot of great physicians out there. And they're really good at what they do. And they really care, but you cannot take them outside their lane.
Yeah, you're
Nor
right.
should we expect that of them. And traditional gynecologists, for example, why did they go into gynecology? Because they loved internal medicine? No. That's a surgery subspecialty.
Yes.
They love surgery. God bless them. I've been bailed out by gynecologists doing great surgery. And when I was delivering babies by obstetricians, it was a miracle.
Yes.
You cannot take them into the realm of medicine. There's very few gynecologists. They do exist who do get real interested in treating women and men, treating women in menopause. I've trained several. They're there. I had a consult with one of our trainees today. They're out there, but they're very rare.
It's a good point. I just remember dealing with some really complicated patients, family members with even birth control stuff. That's just like becomes like fine cooking or making a souffle in some people, because you just too much or too little estrogen in a woman, they're all over the map, and you're using birth control pills with these preset combinations, and someone just is having all these side effects. And I would get stuck a few times where I'm like, okay, I'm pretty good at this, but even I don't even know how to help this. What combo would be best because of their breakthrough bleeding in the middle of the cycle? And I would use these books we had, but I would send them to gynae, and I would get so frustrated because you're right. At that point, it would be like they would either see a PA or a nurse practitioner working with them, and they'd say, well, here's your options, the pill or the IUD. They wouldn't even actually help me out, and they would start all over with the basics and almost want to just take them off their oral contraceptive and throw something else at them, or they didn't know. And for a long time, I would get so mad because I'm like, well, this is no help. I was more help but yet I'm stuck.
Well,
and
yeah.
you're supposed to be the expert.
But you were, but it's
to,
because
to that point,
but
you're
it's
really a surgery-based
yes,
specialty.
but it's a perfect point, because that's exactly right. And in subspecialized medicine, you really do want people to stay in their lane.
Yeah.
I mean, you know, you just had a hip replacement about 3 months ago. This guy, that's all he does is hips. Like, I'm sure when he closes his eyes to sleep, he just sees prosthetic hips floating and money falling off of them. You know, that's exactly the person you want to deal with that problem. And it reminds me of when I was an intern. There was the most obnoxious intensivist in the entire, like, he was a pediatric intensivist, and they forbade him from dealing with any more residents or interns because he was so obnoxious. But he said something that is incredibly true and also obnoxious. One of the senior residents was presenting to them. They said, what are we going to do with, you know, what's your plan? And the resident's like, well, we're going to send the patient to the surgeon to see what the surgeon thinks. And the intensivist comes back and says, you don't send a patient to a surgeon to think. You send them there to get something done. Surgeons don't think, they do. And we're like, okay, noted.
And it's true for hormones as well. Once you start diving into the knowledge base and start dealing with patients and see the phenomenal individual variability, patient to patient, the different sensitivities. And with a woman, you're dealing with 4 hormones, the estrogens, progesterone, testosterone, and DHEA. And there's tremendous variability within each one. And woman to woman, you start seeing how much complexity is there. It's not a problem for anyone who wants to learn the material and get the experience. Same as our medical model of all times. You learn some basic background and you see a lot of patients. Right. And you learn it, and it's not an issue. But if you're not doing that, if you're not taking on that body of knowledge, you get much less results. You get a lot of unhappy people out there who are on the internet blogging saying, this is terrible, I can't get this to work, I'm totally discouraged. So that's not...
I want to pick your brain on that, because I know, you know, people listening to this, it's the first thing is, so now you can find these, they pop up all over online, and pretty much pick 30 miles in any direction from where you live, or 50. Now you can find someone that's doing hormone replacement clinics, whether it's through Western or naturopath or a group setting. There's a lot of what I call cookbook places, and I'm seeing, we have some friends that go to one, and it drives me crazy because I think someone just follows an algorithm. And now I've got, you know, friends that are 55 that are having postmenopausal breakthrough bleeding like crazy, and they're more frustrated. And I'm like, well, what are they giving you? Like, the doses that they're giving you don't even make sense. And I don't know that, how is someone supposed to find, or what do you look for, would you recommend in finding someone that's going to give you the best therapy, that knows what they're doing, instead of going from like no help to now someone that's just kind of following a basic algorithm and just
it's worse than algorithm. I mean, it's still the Wild West in treating women and men. It's just discouragingly mediocre to, there's a few good people out there, but there's not many. And yet with marketing, you can make anything look good. And so here's what I suggest. For one thing, read my book, Happy Healthy Hormones. You'll get a roadmap of a certain way of dealing with things. And you'll get a level of depth there that you're looking for, this level of depth. But I think the greatest challenge for women, for example, is to go shopping. That what a woman needs is someone who's expert, who's devoting their career to treating women in menopause with compounded bioidentical hormones. That they're really specializing in it.
Right.
And so they've got to find someone who's gotten some advanced training, unlike neurology, unlike internal medicine, unlike urology. There is no body responsible for this, although there are group, we feel we've developed standard of care and we're going for board specialization that doesn't exist yet. So you got to go shopping. You got to use the following criteria. One, does this provider have special interest in treating women in menopause? Number two, do you like them? Can you do a brief conversation with them? Some of the best ones will do that to get a sense of whether you like them and whether you can work together. Number three, if you want to use any given criteria, how excellent they are, the best ones are using 24-hour urine hormone testing to test the hormones. There's a bunch of other methods out there. They don't work, or they're really scientifically challenged. So you can ask them, are you doing 24-hour urine hormone tests? That's not the final criteria. But if you find someone who's made it that far, they've really looked into this.
Okay.
And, if you read my book, women will have a sense of what the kind of things they will be looking for, what kind of hormones they'll be looking for, how the process goes for them. And then you hold your nose, you take a risk, and you walk into the world and you see how it goes.
But I love it because you're focusing on what's really important now, and there's access to so much information, but it's to educate yourself at least on what your body is doing and what are the basics that you can equip yourself with. Obviously, you're not going to get you can get a medical degree online nowadays, but to get educated in what basic stuff to look for, what they're doing. And I really like that, empowering patients, which is what we were talking about a lot lately, with knowledge and what to ask instead of the blind days. If my grandmother, I would be like, what pills are you on, Grandma? I don't know. I don't even know what this is for. Whatever my doctor says. So I like that.
There's another criteria too. The best of the best have figured out that there's vast individual difference, and that the way that they can individualize therapy, they need the compounding pharmacist to do it. They need to write these custom prescriptions and balances. And there's 8,500 compounding pharmacists in the United States. A lot of them are dealing very strongly in hormones. A lot of them are knowledgeable. So one thing a woman could do, as far as access, and a man too, is find who your neighborhood compounding pharmacist is. And go walk into the pharmacy to talk to the pharmacist, not a phone call. And ask them who in my area is treating women in menopause, and please steer me towards someone that you think is the best in our area, because they're getting all kinds of prescriptions, but those compounding pharmacists are going to have a good idea who's good.
Interesting. Now, I know that at least where we're at and with what we use, most people are ordering. It can be coming from Arizona or Florida or across the country, and using compounded pharmacies instead of locally across the nation.
I mean, there's one in our state, I think.
Yeah.
Now we used to be able to, call to the town next door, and
but I think there's only one up in Portland.
Yeah, I think so. And
because of telemedicine, and because menopause and andropause medicine lend themselves beautifully to telemedicine, you do not have to see someone in person.
There you go.
Except for a testosterone issue.
Right.
You have access to a provider who's licensed in your state, who knows what they're doing. And people can contact us. I mean, I spend 80% of my time training and mentoring physicians, nurse practitioners, PAs, and advising pharmacists on how to do this. So you can contact Bright.live. Very high likelihood we've trained somebody in your area. And a lot of them stay in contact with us. I have weekly grand rounds. We have a 12-hour online training program. We discuss with 25 physicians and nurse practitioners, et cetera, every week, Wednesday afternoon. They're tough cases.
Perfect.
Yeah.
Perfect. Okay. Well, why don't you walk us through, because I know people wanting to hear just a little bit about, let's start with the females, and we'll get to men last. And then we'll talk just a little bit about, first, what about bioidentical hormones is important compared to just the basic mass pharmaceutical type stuff. So why is that more important? And is there even a difference in companies making bioidentical hormones?
Well, we got to realize that human beings have been receiving hormones in some form or another for over 1,000 years. the Chinese aristocrats set up outhouses where young women's urine was collected, and in another outhouse where young men's urine was collected, and they dried it out, and the aristocrats were taking the powder residue. And so this has been going on for a long time. And in the 1940s, the pharmaceutical industry realized that this was a huge need, and they started they started catheterizing pregnant mares for their urine, and they dried out that urine, and that's where the product Premarin came from. And I must say that if the only tool I ever had was Premarin or Prempro, I would go for it. I would use it. You know, it's the earliest of products that were ever given, but you could tell the women who were on Premarin and Prempro, they did better than their compatriots because they need the hormones, and the horses had hormones. But in the 1980s, simultaneously, a compounding pharmacist in Dallas and a pioneer in holistic medicine in Seattle, right south of Seattle, said, you know what? We think that that there is pure, molecularly identical estrogens available, and progesterone and testosterone, because the pharmaceutical industry is putting pure estrogen combined with something, but they have pure estradiol. It's going into the birth control pills. They both went searching to see if they could get the pure hormones. And sure enough, the pharmaceutical manufacturers were extracting a precursor of the hormones from soy and yam and turning them into, in very sophisticated processes, into the very pure, molecularly identical estrogen, the molecularly identical testosterone, the molecularly identical progesterone that was in a woman's and man's body. And so bioidenticals really arose out of that desire for the same molecule. Why not do that rather than do Premarin? 50% of the estrogens in Premarin have never been seen by a human female. They're horse.
Yeah, I'm like, what would make someone want to choose a horse? I mean, why not a pig? Why not I don't know,
well,
pick another animal?
There were large animals. When they were pregnant, they put out huge amounts of hormones and huge amounts of urine. That's why they chose it.
Just ease of access, basically.
Yeah.
Yes. And there's no elephants in North America.
Oh my gosh.
Right. No,
I don't know.
They should have chosen elephants. Right.
Yeah.
So that's, maybe that's where that mane and tail hair shampoo came
See,
from.
I would have used elephant and rhino testosterone and called it Elefino, which would have been spectacular.
A breakthrough. A breakthrough, Tim. Oh my God, this is a major medical breakthrough.
So now obviously people are, being educated, and it's like you want bioidentical because it says that it's the most closest thing to human hormones that we make.
It's identical molecularly.
Correct. Right.
And it's like anything. The very first computers were the size of a room. And nowadays you can get it on a phone. Things have improved in the world of computers. Well, they have in the world of hormones as well. And the compounded, as I mentioned this before, the biggest difference is you can customize these formulations. Like there's some women, they need this much estrogen to be fertile, to be young, to regularly menstruate. Whereas other women, they need 3 times that amount of estrogens.
Right.
All of these women are normal. Everyone in between, they're healthy, fertile, and can be pregnant. But the variation is over 3 times one woman to the next. That's just of the estrogen family. They have the same variation in testosterone and in progesterone. And when you try and put all those together, if you don't individualize it, you don't get great results. And we know what great results are because we can measure it. And there's medical literature that tells us how much is too little and how much is too much. So the great advantage of compounding is that you can individualize it. There are other advantages, but that's the big one.
Right. I always love doing testosterone levels, and a normal level is 300 to 1,000. And I'm like, yeah, that's like looking at my stock portfolio and saying a normal level is minus 2% to plus 50%. I will take the plus 50% 100% of the time. I mean, it just seems completely insane. some of these normograms that we come up with. I mean, it's not potassium and sodium. We know exactly what
Right, exactly. It isn't. That's a
Right.
great analogy. And to someone who spends, like you said, Tim, going to sleep thinking of the hormone pathways and seeing patients 40, 50 hours a week for 5, 10 years, dealing primarily in hormones, it's not hard. It becomes pretty easy. Like the surgeon who's done 1,000, or the urologist who's done 1,000 prostates. That's the surgeon you want.
Right.
You want an obstetrician who's delivered 1,000 babies, preferably. You're gonna, if they're decent people, you're gonna do best with them. It's the same with hormones. It's relatively easy when you really have that background, that intention, that interest, that experience. So we just individualize, that's all. And we do it through a very simple process of dose determining. And then when we confirm it by proper testing, we know what too much and too little is of all 4 of those hormones.
What are your thoughts on soy? So now there's a lot of controversy and different physiologists I read and listen to talk about using soy instead, or if you're already taking hormone replacement or bioidentical hormones, having too much soy. Is that like a myth? Does it matter? What are your thoughts?
It's a myth. I think there's elements of it that are interesting. But when a woman or a man, when we lose our hormones, you can try flowers and plants and herbs, which are really medicines, and you can get minor symptom relief, but you can't even get near what the actual hormone could do. And it's sort of deceptive. And soy's like that. Yeah, soy has some estrogenic activity, and yet to try and achieve what a woman wants and needs for her mind, for her arteries, for her vagina, for her bones, for muscles with soy is pure folly. It's not 1,000th of what you need. It is true that soy eating cultures, like in older Japan a while ago, not so much now, there tend to be less risk for breast cancer. So there was some kind of protective benefit of soy. But cancer is so complex, you don't want to rely on soy as your only tool for preventing cancer or for treating menopause or andropause. They're trying to work around laws, really. They can't get their hands on the actual hormones unless you are professional and licensed and trained to do so. And there's wisdom in that. These hormones are the strongest biochemicals in our body. You want these to be prescribed by someone who knows what they're doing.
Right.
Absolutely. It's fascinating because we just had an experience, a family that we've known forever, friends of ours. I delivered their last child, almost 20 years ago. And, I had talked to this woman and I said, look, I'm going to help. Basically, I was essentially the head coach trying to screen for to call the correct play. And I said, okay, this is what you're going to look for in somebody for hormone replacement. I'm not going to do it. I don't have enough experience. I feel fairly confident in replacing men, but like you said, there's 4 different variables in women. You got to have your head in the game and know what's going on. So I sent her off. We bumped into her at a party this weekend, and it was like she was almost in tears because she had been given every other pharmaceutical for every other symptom, as you can imagine, mood, sleep, et cetera, et cetera. She's like, I'm off of everything. This is all I take. It has completely changed my life. And I'm like, well, that's exactly the point, because you're being treated with what you need. And we have been blocking this in allopathic medicine. It is incredibly sad.
Yeah, it's so big when you stop and think of it. And I've spoken to professionals about this, like what percentage of women and men in nursing homes and assisted living facilities are there simply because of diminished hormones? We guess 80 to 90%. They get sarcopenia and osteoporosis. They're in wheelchairs, diapers, and their cognitive decline. These are huge issues for us. We think, I mean, just to name a few of the issues that take place.
I was just about to ask you. So, knowing now, the studies that are coming out about low levels of multiple things from magnesium to especially hormones and the influence of Alzheimer's, and as you mentioned, the downstream effect of having poor bone density, falls, muscle wasting, losing mobility, and then the issue with aging and the lack of hormone influence. Do you think we'll get to the point where hormone replacement is a recommended thing and everyone through, menopause or whatever menopause you want to say for men? But if we thrive and live so well while we're reproducing, and our life expectancy now has gone beyond what it was 100 years ago.
We've managed
to mess that up with COVID.
To have that. No, we've managed to have that decrease over the last 10 years because of Cheetos, candy, and soda.
Right. But my point being is that we used to live shorter lives. We live, you're thriving when you're young and reproducing, and then all of a sudden you get to be 50, and not for everybody. Some people feel great, but for the most part, when you think you could prevent a lot of horrible effects of aging and live better younger, should we be looking at hormone replacement in men and women across the board come, say, 45 or 50 years of age?
100%. These are the most powerful biochemicals in our body. As a gerontologist lectured to us when I was a senior medical student, you all know thousands of diagnoses. You're senior medical students. Well, let me tell you what's happening to older people. They're getting sarcopenia, they're losing their muscles, they're falling on their osteoporotic bones, and back then they were dying. And he said, you want to do something for older people? Take care of their muscles and bones. He wasn't mentioning their brains,
right.
or their arteries.
Right.
And these, you take adequate androgens, you don't get sarcopenia, or you get minimal diminished muscle strength and mass. You're able to walk and stand with stability. You take estrogen at the right time, you don't have to lose your bones. You don't have to get osteoporosis. And the arteries, the protection of the arteries, estrogen is so important to protecting the arteries. And women have a much different risk for heart attack after they lose their estrogen. And function of the brain, it goes on and on. These are the most powerful biochemicals in our body. The absence of them affect us everywhere, and it doesn't need to happen.
Well, and to your point, that's was always our answer, as we become more learned, is like if someone's lacking insulin or thyroid hormone, we have no problem replacing that as a physician, or you don't produce any more cortisol. Well, that's a medical emergency itself. But when it comes to sex hormones, it's like, oh, no, you don't need it anymore. Well, why don't I need it anymore?
Right. And then you look at two people come to mind. Sylvester Stallone, who's 75, 72, and Geraldo Rivera, who is, believe it or not, over 80. What do you think the chances are that they've been replaced adequately?
Yeah.
They 100%. That's the point. If you eat right, work out, and have adequate hormone, treatment or supplementation, or however you want to say this, you actually can be really strong and vibrant and sexually active and all of these things you want to do into your 8th decade. Instead, we got so used to people dying reasonably young, before World War II and then shortly after World War II, that you expect, my grandfathers were born in 1900, and they were actually both fairly vigorous, but my grandmother's, kind of just got old. Like nobody colored their hair or anything. And you just, okay, well, you're 55, you're old and you don't really do anything. And you sit around and you kind of gain weight and you don't really care about life. And I'm like, well, I would prefer something different than that. Thank you. And this is where we are.
I want to know, if you don't mind. So
then I have two questions because men's lives
matter. Absolutely. So a lot of focus has been on estrogen, progesterone, and testosterone for women. I think more so DHEA, but not a lot yet still. So without having read your book yet, what would you say to the DHEA, what role it plays for women, how to take that or look for that as a supplement? How do you combine that?
I would call it ancillary, and yet it is more prevalent milligram for milligram than testosterone, estrogen, the estrogens, or progesterone, and yet it doesn't have as distinct deficiency symptoms. In fact, it is a biochemical precursor to testosterone, estrogen. And what I learned long ago is you never try and give the precursor, you give the end hormone. Like you could feed people butter. Butter eventually becomes the sex hormone with the cholesterol in it. It all starts with cholesterol, but you have no control of how much and what pathways it takes. So we always treat with DHEA. In women, by the way, if you're taking DHEA orally, do not go above 15 milligrams a day, even though you can access higher than 15 milligrams. Be cautious with it. You just want to get the right amount. And a lot of our women are on 7.5 to 15 milligrams. You want to get that specific too, ultimately as demonstrated on the 24-hour urine hormone test. So that about DHEA. But I'd like to give prominence to testosterone for women. There's more testosterone in a woman than there is estradiol, her most potent estrogen. It's not a male hormone. It's a human hormone. And that's what's going to preserve your muscles and your mood, a lot of stuff in your bones. And estrogen, we recommend something called Biased. It's a combination of two estrogens, estriol and estradiol, and progesterone. Oh my God, so many women would do so fantastically better, mood-wise, sleep-wise, if they were on progesterone. They all count. Whereas DHEA, we always give it, but we don't expect it to do anything other than be the precursor it is.
Okay.
And we ultimately determine how it's behaving through the 24-hour urine hormone test.
Okay, that is a perfect segue to tell us how and where, if me, country doctor still, I want to do a 24-hour urine hormone test on a patient. How would I do that?
Well, for one thing, we never test women in the perimenopause or early menopause because women who are no longer having a period, they would get the opportunity of spending $300. However, you would learn that all their hormones were low. So,
right, which you already know.
Thanks a lot. If you test a woman in the perimenopause, what's going on, instead of those nice smooth menstrual curves that we saw in medical school, where there's a pretty specific output of estrogen, for example, things get really erratic. You can get highs so high and lows so low because the ovaries are failing. And when the hypothalamus detects low estradiol, for example, it tries to remedy it by putting out a stimulating hormone from the pituitary gland, and you get highs much higher than a young woman ever had. Mm-hmm. But you're oscillating, and overall, the course of the month, the woman is definitely low in estrogen. Well, this is how I learned that. I tested a woman in the perimenopause. She was having hot flashes. I knew she was low in estrogen. And I did a 24-hour urine hormone test, and I showed her test results that her estrogens were high. And I said, but I still want to treat you with estrogen. And I got a look from a patient that, am I out of my mind? You tested me and I'm high and you want to give me more? So it's perilous to test, and it's no value to test in the perimenopause. Symptoms alone are going to teach you that women are low in the estrogens.
Plus, doesn't it matter? I mean, pick a given part of the month. I mean, if you do it day 1 or day 18, it's going to be all over the map anyway. If women's hormones are bouncing around. That's
another reason to not do it.
Right.
Now, we test 100% of the women and men, for that matter. But just talking about women, we go on a journey with a woman that lasts between 3 and 6 months to help optimize her hormones by symptom relief and alleviation. And then when a woman reports to us, wow, I am myself again. This is fantastic. And that's the only result we accept. We want that testimony.
Perfect.
We test 100% of the women. And one of the things I did is I went into the medical literature to define what's too little and what's too much. And it turns out that even if women have symptom alleviation, 75% of them are not going to be in the optimal zone. 50% will have too little estrogen to protect their bones and their vagina. And 25% of them will be on estrogen doses a little too robust that put them at risk for breast glandular cell proliferation. So we know this from a study that I personally did. And so when they say we're great, we test them, and at most we do a little tweak. We don't have to test them again. And then we test them annually.
That's good to know, because a lot of people, including myself, I've just gone based on symptoms and kind of adjusted my dosage accordingly without doing a level. So I could be, and I, in all honesty, drop my estrogen lower because I'm like, well, isn't less better if I'm still having symptom relief?
No, it's not
but
true.
So good point. So people still should be doing a test if you're going to use this to make sure you're optimized. Okay.
100%.
So when you get into men, okay, so the thing I would see in allopathic medicine when people were like we talked before we started recording, where they get a big whack of depot testosterone and the doctor assumes it's going to last for a month or 3 weeks, and then what they're doing is they're converting a ton of this into estrogen, and so they're not really getting that much of an androgen effect, but they're getting estrogen side effects, man boobs, etc. What kind of estrogen or estradiol, or what estrogens do you even test in men? Because obviously if you're going to replace them with androgen, you need that. It's the balance between your androgen and estrogen levels. Too much of either one is going to be a problem. And so what's your guidance there?
Well, I want to back up to complete the answer. You said, where can I get this 24-hour urine hormone test? Where else but in Portland, Oregon?
Yes, exactly. They're harvesting it from bum camps, obviously. Sorry.
There's two great 24-hour urine hormone testing labs in the United States, and one of them's in Portland. Its name is Rhein, R-H-E-I-N.
They're doing something right up there. There you go. Yay.
There you go.
Okay.
And then for men, it's a myth that men are easier. That myth arises because, hey, a man needs testosterone, just like you were describing, Tim. Just give him a bolus of testosterone. Well, that was the primitive way to treat. And, those men did better than others. But there's as many moving complexities to men. So, for example, when we do initial blood testing on men, we test their total testosterone, free testosterone, their estradiol, plus estrone, their sex hormone binding globulin, their DHT, their LH and FSH. And if you don't test all of those, we also test their prolactin and a few other things. You can do exactly what you described, is get into imbalances so quick that you can lose all the benefits of testosterone and start getting the mega side effects. And that was the ritual. The ritual was blast the men so they get super strong and great libido, but what they don't realize is they're getting overdosed. Well, we've taken this a lot farther. In fact, even with testosterone injections, nowadays, if you talk to physicians who've done some studying about testosterone and they're still using injections, they're doing it twice a week because you can't get a dose high enough, like you were saying, once a month, and it's going to deteriorate as time goes on. So you can't get that right. So currently, some of the better work that's done with injectable is done twice a week, but that's not good medicine. If you were going to use injections and do it properly, you do it daily. So you wouldn't get these high peaks that have to last you 3.5 days. Those high peaks, what they do is they reduce the LH and the FSH, and you'll understand what I'm saying here, and I'll explain it more if you'd like, to near zero, in which case a man's going to get testicular atrophy. Okay, well, how big of a deal is that? Women get ovarian atrophy. It's not that big of a deal, but many men don't like it because you can't see the ovaries, but you can see and feel the testicles. So if you don't want to give a man testicular atrophy, you better watch out on how you're dosing. The proper way to dose is daily. So we have a topical daily dose. This is my testosterone. I take it every day. It's in an organic oils formulation. It's a suspension. I have to shake it, and you apply it daily so you avoid that high peak and then decline. And then that high peak can also raise the sex hormone binding globulin. And without going into details there's other moving parts that you do not want to raise. You don't want to raise the dihydrotestosterone. You can get hair loss from that. So the main thing is, I find it is interestingly complex to work with men as it is with women. You wouldn't expect it to be anything different. I think just men his hormones just haven't gotten as elegantly individualized over the course of time as women. There's been a lot of focus on bioidentical hormones for women. So the state of the art is in a great time to take hormones, I'll tell you, because so much good stuff is known. And in men, you want to get all that stuff right. Like I spoke to a man today that when he was on injections, his libido was really high. And when we tested him on day 3 after his injection, he had high estrogens. He had raised up his sex hormone binding globulin, totally suppressed his pituitary. So it used to be something that men, well, they like the immediate effect, but they don't like the long-term effects of breast enlargement and loss of libido and crazy mood changes. So moral of the story, if a man is going to receive hormones, all they have to do is get educated go to someone who's gotten the advanced education. By the way, Tim, we have that. We have a 7-hour training program online and grand rounds for people treating men. And lots of moving parts. The great thing is if you find someone who really focuses in on it, they'll get it. It's not that hard. Men or women aren't that hard when you spend the time to really hunker down and get the knowledge and training.
Love it. What's your thought on then, pellets, using implantable pellets versus injections, creams, oral? Is it, the simple answer, kind of a combination of all of them, depending on what the patients want as far as what they can tolerate, if they don't want to use topicals, creams. We've heard that if someone doesn't want to stick a needle in every day, then implantable pellet's nice because it's time release. You don't have to worry about it. Do you have any pearls in there of advice for patients on this is better no matter what, or whatever works best?
Well, let me see if I can give you an analogy, because you delivered babies, right, May? And did you too, Tim?
Yeah, it was primarily me. I did it for 12.
I was trained in it. I didn't do it in career
12,
just because I like
12
sleeping.
years.
I like my nighttime 8 hours of sleep.
Well, I challenge you. I'm going to make a guess about you that you never said to a woman, well, you're getting lower fetal heart rate here, but here's some choices we can do. We can rest longer, or we can give you. It's not a matter of offering choices to someone. They're relying heavily on your skill set and your knowledge. And not only that, they want you to do it
right
properly. And there's a wild west in hormones because it got that severe stunting. So there's people trying all kinds of things. There's a big financial motivation to providers in doing pellets. It's not physiologic. I was talking to a pellet person the other day that they wanted to do a podcast with me. I said, you probably don't want to do that because at this stage of my knowledge, there's no way I could be an advocate for your business. That would probably be harmful to be on there. And I said, but here's something, I'm open. Why don't you show me a study where someone did blood tests every single day for 3 months so we know what those pellet levels are? Are you getting these huge increases with a gradual decline? So you're doing a variable, non-physiologic thing to the human body. How high do your levels have to get? On the flip side of that is I was invited to testify in front of the National Academy of Science, Engineering, and Medicine Select Committee on compounded bioidentical hormones 3 years ago. And they let off my day. My goodness. Sorry.
That's all right.
They let off my day with the district, the many people who are going to testify that day, with Assistant District Attorney of Tennessee, who just read the Riot Act about pellets and the great work that they had investigated and really reprimanded and got the businesses to close that were dealing pellets because they were getting so many adverse responses. Now, I think pellets in the hands of someone who's specializing in it and really took the time to figure it out, a decent job could probably be done. But that's not what I find in the pellet world. I find a lot of women and men that were overdosed. You can't get the pellets out. It takes us 3 months to dial in the optimal dose for any given women, and we can vary the dosages on a daily basis. They stick a pellet in, someone who's highly experienced, they might get it right. But
I love this response. I mean, because it was what my thoughts were too, having heard about it, and I have friends requesting it. And I just think back to when we did the implantable birth control, the Implanon, and oh my gosh.
Well, it still exists. It came back.
Nexplanon, Implanon.
Yeah,
I forget they keep changing it, but it was awful. And B, those things got scarred in there. And sometimes Tim and I remember we together were trying to take these things out it took 2 hours because they got scarred in there, but you couldn't control what was happening in some of these women and girls.
Well, they put him in a 17-year-old, and then she'd gain 100 pounds and come back and want them taken out. And I'd spend like this I became sort of the specialist in our clinic in taking them out. I kind of perfected this technique, and it was still like being tortured.
So that was my thought on pellets. So how you control something that just is this time release thing. Yeah, I didn't know how great that was. And
certainly some pellet people would want to debate me on this. But if you go onto the internet, you're going to hear various people commenting on the problems that they have about pellets. So until they perfect their art, which is hard for me to imagine possible, I don't even like twice a week injections.
Okay. So what about progesterone cream versus oral? Any thoughts on that? Is it easier just to control it orally versus cream?
Well, again, when it's topically applied, I prefer the organic oils. When you see a jar of progesterone cream or any cream, what people don't know, and I learned about, was over 99% of what's in that jar is strong solvent, because these steroid hormones are very poorly soluble. In fact, chemistry texts say try acetone or formaldehyde. Yeah. Well, you don't need that. The compounding pharmacists have gotten a lot more gentle than that, but they're still strong solvents. And I was always a holistic doc. And one day I figured it out. I opened up a jar of Biest, and out came the strong odor. And I investigated, and I went, oh, it's the strong odor of the solvent. Mm-hmm. And I did the math. I said, well, here I'm detoxifying my patients, and I'm asking women to apply a quart a year for 10, 20, 30 years. What's wrong with this picture? That's when we set out to develop the organic oil delivery system.
Okay.
So, but if the only tool I had was creams and gels, I definitely would use it. And progesterone absorbs really well. And unlike other steroids, it's not the safest to give estrogen in a pill form. When the birth control pills came out, there was a significant proportion of women, small that it was, that got thrombophlebitis and pulmonary embolus. And there's reasons on how oral estrogen performs to promote liver coagulation and inflammation proteins. So you don't want to give estrogen orally. You don't want to give testosterone orally. You can really injure the liver when you do that. But progesterone you can give orally.
Right.
So we have about half of our patients on oral progesterone. And for a woman in perimenopause, topical progesterone can do so much good. You can even get it over the counter. It's 18 milligrams per milliliter, 1.8%. You can really help a young woman in her 30s who's getting estrogen imbalance because her progesterone has dropped out earlier. So I love the creams for that, although I always prefer the organic oils. Okay. The progesterone can be delivered topically and orally. Both of them are valid. You can get some really high doses orally. I had a dear colleague and friend tell me when we were teaching at a conference 2 weekends ago, she said, boy, I was having trouble sleeping. I took 600 milligrams of progesterone and I felt great.
I know. I hear that.
That's a very high dose. 300 milligrams is not that uncommon by physicians who really understand progesterone. But more commonly, if you're giving oral progesterone, anywhere from 50 to 150 milligrams will serve most women. But I like both methods, and it's always individualized. You figure it out with
Right.
every individual woman, what's optimal for her.
So you mentioned the 24-hour urine test. What about the Dutch test? That's now become this thing you hear about everybody saying, oh, we do Dutch test, get a Dutch test. I don't even know what it stands
Do you
for.
pee into a wooden shoe?
Yes, and you send it to Holland.
Yes.
Because
perfect.
they're experts in wooden shoes. You know, it's I've had challenges internally with the science that they're using. There's issues there. And so we've gone so far as to do split specimens in which we're having an individual patient 24 hours and at every urination to also collect the filter paper for the Dutch test. And we send the 24-hour urine to 2 different labs, and we send the Dutch test to Dutch, and we simultaneously do salivary and blood testing. And we've only got 9 people that we've done this to. We've just decided to do the comparative test because I was uncomfortable with the science behind filter paper determination. Very uncomfortable with it. And so we're going to, before I comment on it, what I'd like to tell you is I can stand with all my heart and soul behind 24-hour urines. That much I can tell you is great. And if you're going to venture into something else, look out.
Perfect answer.
No, this is.
So where can people find your book and start reading that for getting educated and more information?
They can get a free PDF copy if you all want to offer it on your website.
Would love to.
You could contact Sherry or Karina, and they'll give you a link, and they can just download the whole book PDF version. They can purchase the printed version on your common supplier of such printed stuff these days.
Awesome. We can
Yes.
put the links in, but yeah, we'll get a hold of that.
You mean the
so
place that's owned by the guy that makes giant penis-shaped rocket ships?
That would be the place.
I love it. I love it. And then we'll put the link in for the menopause method as well as bright.com and
Bright.live.
Sorry, bright.live.
Bright.live, yeah.
And I don't know, I might be on there sooner than later.
No,
educated myself because every time I tell myself, I don't want to. I like to learn it for myself, but I don't think I want to treat patients. Then I just get so fascinated, and I'm like, maybe I should just do it.
Maybe we should just do the course, and then, I mean, we're trying to figure out how to do more of a.
Here's my promise to you that if you like this work, and you do our course and you do our grand rounds, you'll arrive at where you'll go, wow, I did the right thing. This is great. And if it's not great, we'll give you your money back. And we'll make a deal with the 2 of you anyway.
Yeah.
But I think that looking back, there's a few things in practice. One of them is, for sure delivering babies and helping people through death and dying. But man, hormone replacement has been one of those things where you can change a life so quickly, and it's amazing.
Well, but here's the reality. You don't change one life when you do this. You almost always changed at least 2, because sex hormones, it's not just about sex. It's about feeling, like your old self, whether you're a man or a woman.
Well, and it affects your closest relationships.
Right. And it isn't just that, all of a sudden you have sexual function back. I mean, that's great. But from my perspective, that's the bonus. It's that you sleep better and your mood is stable and you can work out more and you can focus, your, mind is clearer, like all of that stuff. And I'm like,
well, just it impacts people's relationship with other people. I'm like saving the world instead of world peace. It should be world hormones, right?
It impacts my relationship with not wanting to flip off people in traffic, if that counts. I mean, it really is. I mean, it's just such a big deal. And the fact that it hasn't just been ignored. It's been, like I know I would have this conversation with a bunch of my colleagues, my age, guys I went to medical school with, and they'd go, you're on TRT. And I'd say, yeah. And they're like, you're going to get prostate cancer. And I'd be like, no, that's exactly why I'm not going to get prostate cancer. which is the more correct answer. It's like, why do you think your prostate explodes when you're 70s? Because you have all this estrogen and it's not counteracted by testosterone. And, you know, it just goes, it's all right.
That's his alarm telling us.
Yes. No, we could go on.
Well,
and
it's
on.
not. It's,
I'm kidding.
somehow I didn't get my phone off.
No problem. Well, this has been awesome. I know we're going to get a deluge of questions and people wanting copies of your book. So thank you once again for your time, your expertise, what you're doing. And we will put all those links in and maybe have you back on again to just go into more detail and share some more information with our patients.
It's been fun being with a husband and wife physician team. Oh my God.
That still like each other.
Exactly.
That's beautiful. And yes, I'd be delighted to come back. It's an honor.
Thanks again.
Well, I found that incredibly informative, really added on to the other discussions we've had with Robert Yoho as far as hormone replacement and treatment, and confirmed a lot of what I was thinking. I'm very curious to explore his topical preparations where he's not, he's using these plant-based substances instead of, the powerful solvents.
Well, we know how great solvents are for you. Just all that information about sunscreens and how toxic that stuff was. So can you imagine if you're daily putting massive, quantities of hormone replacement therapy creams, topicals, rubbing them on your body? It's just like, yuck. Who wants to put all those solvents on there?
Yeah, but yet somebody I know that is sitting next to me puts on tons of sunscreen every day, which is why she looks so young and I look so haggard.
But I
spend a lot of time in the sun.
The healthy sunscreen.
Okay, right.
I'm talking about the toxins that are the binders that hold the sunscreen.
I don't know.
You got to get the good stuff.
I've been all over the map on hearing people talk about whether or not sunscreens are good or bad, and I don't know. I don't like getting sunburnt, but
But you get to absorb more vitamin D than I do, I guess. So
yeah,
food for thought.
Yeah, but at any rate, I think the bottom line on this interview was hormones are the most powerful biochemicals in human medicine. And I add, then why are we ignoring that? That doesn't make any sense.
Why are we denying people them? Which has always been our point.
Yeah, you would not deny somebody thyroid hormone. You would never deny them insulin, which is a peptide, kind of a hormone, but a small one.
Yeah, and so when us women are going crazy in menopause, hot flashes, feeling mentally anxious, depressed, psychotic, and all Western medicine docs want to do is throw more Xanax, benzodiazepines, sleeping pills. It's really kind of frustrating and pisses me
Well, when you look
off.
back though, it's fascinating because if you look at the most popular drugs, about when we just before we started medical school, it would have been the late 80s, and for sure in the 70s, the most popularly prescribed prescription drug, at least in Canada, and I assume all of North America and probably all of Western medicine, was Valium.
Mm-hmm.
So benzodiazepines, so anxiety medicine. Of course, that fell out of favor when we realized that people become addicted to it very quickly, and so that's a bad thing, obviously. Interestingly, the drug that knocked Valium off the pedestal was Tagamet, which was the antacid drug. And then
nothing like growing man boobs with a bunch of Tagamet.
Well, yes, correct. And then later on, that was knocked off by Zithromax, which is a little horrifying.
Yeah, no kidding. The Z-Pack.
And then Prilosec came in and took the throne again. So it's fascinating when you look at a lot of these problems, though. Like you look at Valium being, the number one prescribed drug for who knows how many years. And you sit there and you go, well, how much of the Valium is people are anxious or they have bad lifestyles, they're not eating well, they're not exercising enough. I mean, that's clearly part of it, but how much of it is they were just hormone deficient and could have been treated in another way with wild health benefits that would treat the actual symptoms without the downside risks, without the addiction problems, and with tons of health upside. Exactly. So, and that's what Robert Yoho said. He was like, he was treating all these women with cosmetic procedures, liposuction, et cetera. And really all they needed was hormone replacement.
Well, don't you remember I would still read it in the literature now, but not that long ago, we were trained that when people are going through, especially women going through menopause, it's like, well, address the symptoms. You can like alleviate a lot of possibly hot flashes, but especially anxiety and sleep disorders by giving them Lexapro or pick your antidepressant of choice. Some work better than others. And I'm like, really? Well, why not just have some hormones and restore your luscious, soft skin,
because
lubrication and mood? But no. Anyway,
because
it is funny.
Like seriously, like think of that, like put that, like just think of that rationally. Okay, you could treat the actual source of the problem, right? Which restores vitality, muscle mass, sexual function, and desire. Or you could treat somebody with an SSRI, which causes withdrawal symptoms when you try to get off,
decreases desire,
obliterates sexual desire, causes sexual dysfunction in virtually 100% of men that use it.
And now, as actually our good friend Dr. Sabine Hazen said, can actually probably disrupt the gut microbiome with SSRIs, which that would be another fun episode to do with her. But
yeah, so
anyway,
and that stuff was,
we put our stamp of approval on hormone therapy, and I don't know, maybe we will both get certified in this course, because I know enough of you guys are asking us, and we really have an interest in it.
And I'm really interested in David's products that he and his son have developed with this transcutaneous, topical treatments, no injections,
maybe
better
we should
steady
stop
state.
experimenting on ourselves and actually get our levels done correctly, though.
Yeah,
that would be a good idea.
I don't know. I like experimenting.
So have you guys been following our escapades across the country? You will notice that we are still in bleak and dreary Oregon. We haven't moved yet. We are working on things. We hope you enjoyed our little move as much as we didn't. Let's just say moving sucks. Tim has nothing to say. It was all pretty much documented on our social media posts. When you have a lot of stuff over 30 years. So anyway.
Yeah, that looks like we'll be moving again in 6 months. So we're only going to get.
Pray about that for us. But we'd like to make a little plea that we really want to help get the show noticed on Apple and Spotify. Those are the top two social podcast platforms that people tend to listen to. So if you can, as soon as you're done listening to this, go and rate, review, give us a 5-star like, and just write something on the Spotify or Apple podcast platform. It helps the show get bumped up to the top, helps us get noticed, helps us get more quality guests as well, and helps us get seen. So that is what you can do as a listener to help us out. And we also just ask that you share it with someone and see if they like it. Also, a little teaser, we are planning to do some Doc Tales with Cocktails episodes live, coming to you weekly. We'll put some more info out on that on our social media, on Facebook and Instagram. But we are going to be doing a live show for about half an hour, and we'll have time for guest questions possibly at the end. So a little different format, a little different information. So keep an eye out for that this week. And with that note, hope it's sunny where you're at. It's not here, and we will see you next time. It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
try to keep BS-free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.